This is your bowels working normally. This is if you have a bowel obstruction. I'm Dr. Harris. I'm a general surgeon. And today we're going to talk about how to diagnose, treat, and manage bowel obstructions. First thing is, if I get called about someone having a bowel obstruction, usually they're saying they have nausea, vomiting, they're not passing gas, and they're not moving their bowels. So my first question is, well, what's causing that? If they have a bowel obstruction, they probably had a CAT scan, and that CAT scan is going to give us a lot of information. The two most common reasons for bowel obstruction are adhesions, which means there's scar tissue that's caused the bowel to kink on itself and kind of twist. You can have scar tissue there for years from prior abdominal operations, and it may be fine, but then all of a sudden one day it may twist on itself and then you have a blockage. Well, that's something that can need surgery, but not necessarily. It depends, and we'll go into that a little bit. The other thing is if it's stuck in a hernia. That's the other most common cause of a bowel obstruction. If you have your bowels stuck in a hernia, a hernia is like a hole. It's a defect in the abdominal wall, and let's just say you had a belly button hernia. And you have this hole there, and all of a sudden a loop of bowel gets stuck in there. Well, that is going to cause a blockage. And the thing that's dangerous about that is if you leave this in there and you don't take care of that immediately, the bowels could become strangled because it's almost like a tourniquet. It's like a rubber band has been put around the bowels. And if it stays like that, this segment of bowel that's stuck in there, it's going to die. And then it'll perforate, and then the person could die. So as a surgeon, if I get called about a bowel obstruction and they tell me that the CAT scan shows that it's stuck inside a hernia and they can't push it back in, I need to come in immediately and take care of that, because if I don't, the patient could die. So first thing I do is, if I have to manage something like that surgically, is I need to operate and I need to get the bowels back where they're supposed to be. And then I need to look at the bowels and make sure they're healthy. If they're not, well, I may have to cut off a segment of that bowel and then put them back together again. But if it's healthy, that's great. Now I just have to close up the hole. Sometimes we have to use meshes, and that's a whole other talk. But the main goal is, if I need to do emergency surgery because the bowel is stuck in a hernia, I get the bowel back inside the belly where it's supposed to be. I inspect it. If it's bad, I remove it, and I put them back together again, and then I close the hernia. Going back to adhesions. If you have scar tissue from prior abdominal operations and it's caused a bowel obstruction, sometimes people could get better just with a nasogastric tube. That's basically a little tube that we have the emergency room team place down the nose of the patient and push it down into the esophagus and into the stomach, and we basically hook it up to suction, and it sucks out all the fluid that's backed up. Even if you're not eating, the stomach, the small bowel, the pancreas, the liver, they all secrete a bunch of fluid, and that fluid can build up and could cause a blockage that could perforate if you don't decompress it. So usually people vomit, but sometimes if you get what's called a closed loop obstruction, the bowels could kind of do something like this, and there's an area where the bowels are twisted where nothing's going either way, and everything upstream could cause people to vomit, but the middle area, nothing's going anywhere. And unless you untwist that can cause a perforation. And sometimes patients may not present with nausea and vomiting because the bowel obstruction is so far downstream that they could be very bloated and distended and they're not passing gas, but it may take hours and hours before they actually start vomiting. But the CAT scan will tell us if there's a blockage. So usually by putting the NG tube down, if it's just a plain old bowel obstruction with adhesions, if you want to try to treat it without surgery, which is what most of us try to do, is we allow them to have the nasogastric tube, connect it to suction, and we just wait until they start to get better. How do we know if they're getting better? Well, we follow the output from the NG tube. We see how much is coming out of it. If it's putting out a whole lot, that tells us things aren't going through. They're probably not ready. If they're passing gas, that's great. But if they're not passing gas, then that means that things aren't going in the right direction. If their belly's distended and they're still having pain, they're probably not getting much better. A lot of these things are based on how they're doing clinically. And it takes some time to figure out if they're going to need surgery or not. Sometimes it could be days, sometimes it could be up to a week. But if they get better on their own, All we do is we take out the nasogastric tube once they're ready, and then we see how they tolerate a diet. And if we really want to prove if they've gotten better on their own, we'll actually put some contrast down that nasogastric tube, and then we'll do x-rays to follow it and make sure that things are going where they're supposed to. If contrast makes it all the way down to the colon, then that means that the blockage is most likely resolved. And then we could be comfortable about taking out the nasogastric tube and starting them on a liquid diet. So the two most common reasons we talked about as far as causes for bowel obstruction, adhesions and hernias. There are other things that we worry about that aren't as common, but it's always on our mind as surgeons. Crohn's disease is a very common cause for bowel obstructions outside of the other two mentioned causes. It's an autoimmune disorder where the immune system attacks anywhere between the mouth to the bottom, anywhere in the GI tract could be affected by Crohn's disease, and it can cause a blockage. Because of the nature of Crohn's disease being a lifelong disorder that requires medical treatment, usually first, we don't jump into surgery immediately unless there's a perforation or the blockage isn't getting better on its own. Crohn's disease is one of those things that if you keep cutting out bowel, that disease is affecting that patient for the rest of their life. And the more you take out bowel, the less bowel they have left. And at a certain point, they're not going to have enough bowel to live off of. So we don't jump into surgery unless it's absolutely an emergency for Crohn's disease. And eventually it does get to that. Another thing that we worry about is cancer. Cancers could affect anywhere in the GI tract. Small bowel cancers are rare, but there are many cancers that we have to worry about. Carcinoid tumors are one that affects the small bowel, and then there's adenocarcinoma, and there's all kinds of different versions of tumors. Desmoid tumors, there's different things, but for the purposes of this talk, we're just going to say cancer can cause a bowel obstruction, and that's not something that's going to get better with medical treatment. It's going to require surgery to cut that cancer out and put people back together again. As a medical student or a resident that may be taking care of patients with the bowel obstruction, the first thing you need to do is figure out what the cause of that bowel obstruction is. And sometimes you may not know that immediately. It takes certain diagnostic tests. Typically a CAT scan with oral contrast is preferred. And based on the diagnosis, this will lead you to what the treatment modality is going to be. Some bowel obstructions could get better without surgery and some need surgery, but that's the decision for the surgeon to be able to determine when and why someone would need surgery. As far as the patient's perspective, I know it can be very frustrating having nausea, vomiting, not being able to pass your stool, and having a bowel obstruction could be very uncomfortable, and having to be in the hospital, not being able to eat, and having a nasogastric tube in could be uncomfortable. Some people, they ask, well, can't you just go straight to surgery? Why do I have to wait with this tube in my nose? And the answer is, even if you go to surgery, you're still going to get the tube in your nose, and it's going to take some time for the bowels to wake up. But if you don't have surgery and you get better on your own, isn't that a better option? And typically they'll say, well, don't you need to go in there and cut all the scar tissue? The answer is maybe. Sometimes if you go in there and you cut all the scar tissue that you see and untwist everything, it may reform in a way that's not very favorable. And sometimes people could get worse. And in the process of operating, you may end up causing a bowel injury in the process. So it's a good idea just to be patient and try to allow the surgeon the time to be able to make the right decision, because sometimes we don't know when to operate, and it's based on how you do clinically in the hospital as we're watching you. It takes time, and sometimes it could take days before we make that decision to operate. And it's all just because we want to make sure that the timing is right for you. If we operate on you too soon and then you end up having a bad outcome, that was a bad decision. But if we don't operate for a few days and you get better on your own and the bowels just untwist, you may just do just fine, and you may never have another bowel obstruction. Could just be bad luck. So it's really important for us to be able to determine what's the right move for you. If it's adhesions, a lot of times you could try to treat it with a nasogastric tube, and a lot of times it'll get better on its own. If it's stuck in a hernia, that's surgery automatically. And we typically don't sit on those type of things because it can cause a life-threatening emergency. Cancer, obviously, that's going to have to come out if it's something causing a blockage. And Crohn's, as I mentioned, it's one of those things that you try to get by without surgery unless your hand is forced, because you can only do so many bowel obstructions, and Crohn's is a lifelong disorder. So let's say that you do have to have surgery. How is that surgery going to be done? Open versus laparoscopic. And sometimes laparoscopic could be robotic assisted. I'm not going to go into a lot of detail about robotic surgery. It is something that I do, but please comment below if that's something that you're interested in. But the big topic is open versus laparoscopic approach. If I do an open surgery, that basically means that I make an incision on the abdomen and going in there and I have access to all the abdominal contents to be able to figure out what's going on. Open surgeries hurt more. Big incisions equal more pain. Laparoscopic surgeries hurt less because they're smaller incisions. So the benefit is you get to go in there with the camera and use special instruments to be able to give someone a minimally invasive approach to be able to fix their bowel obstruction. The downside of that is if your hand is forced to operate very soon when the bowels are still very distended and you haven't had time to put a nasogastric tube in and decompress everything, you don't have a lot of room to work in there. And when you go in there laparoscopically with the little incisions and the instruments, your camera may not have enough room to see anything because the bowels may be all in your face. I mean, you may have very little room to be able to manipulate the bowels because the entire space inside the abdominal cavity is all bloated and distended from the bowels. So sometimes it's not safe to do laparoscopic surgery when you have a bowel obstruction. But if we decompress the bowels for a couple days and someone's still not getting better, at least all the gas and everything from the inside of the intestines has been decompressed, and then we could potentially have a little bit more room to work. And the likelihood of having a successful laparoscopic surgery is much higher because you've allowed the bowels time to decompress with the tube in the nose. And then if for some reason we go in there laparoscopically and we feel that it's not safe to proceed, you may still have to have an open operation. Anytime I can consent to patient for laparoscopic surgery, we always say there's a possibility of an open operation because we need to be able to give you a safe operation. And sometimes laparoscopic surgery just isn't safe, and we don't know that until we actually get in there. So the goal of surgery is to go from this to this so the bowels could start working again. I hope this video was helpful, and if you have any ideas about content you'd like to hear more about, just comment below. Take care. Have a great day.